Speak about in my presentation of access landscape and access barriers in terms of treatment of HBV and HCV. So I will start really quickly with some epidemiological data and data on treatment gaps. So first to start with and to say where I'm going to speak from, there are two WHO regions which cover the African continent, which are EMRO and AFRO, and EMRO covers, as Jumana said, a few northern African countries. So in my presentation, when referring to Africa, I will refer to these two WHO regions. So in terms of HBV, we have a huge treatment gap. We have only 10% of people living with HBV who are aware of their status, and only 1.8% of these people who are on treatment. In terms of HCV, we have 19% of people living with HCV who are diagnosed, and only 2.5% who are on treatment. So there's a huge gap to fill in terms of making sure these people access treatment. We can see here that Africa is lagging behind in terms of screening and access to treatment. So in the African region, only 0.3% of people infected are actually diagnosed, and 18% of these people are on treatment. In Eastern Mediterranean region, it's not much better. It's only 1.7% of people diagnosed, and 0.5% only on treatment. For hepatitis C, we are doing a bit better in terms of screening, with 5.7% in Afro region and 7.7% in EMRO. But then in terms of access to treatment, we're still very low. So what medicines do we need? There are recommendations for pangenotypic medicines for hepatitis C drugs. So sofosbuvir in combination with daclatasvir or velpatasvir are recommended combination for all genotypes. And when DAAs arrived in the market in HCV, it was a huge revolution, as it was the first time as we actually had a cure for this disease. And a revolution because this was an easy treatment, which was a cure, which was pangenotypic, and which was a short treatment of only 3 months. In terms of HBV, there is no cure yet, but there are highly efficient treatments. So the WHO recommends tenofovir and entecavir as preferred first line. These treatments have a high genetic barrier to resistance, high efficacy, minor side effects. The posology is oral, so it's also easy to take. And these treatments are also used for HIV, which makes harmonization between treatment and national programs easier because these treatments can be used for HIV, they can be used for people infected with TB as well. Despite existence of this treatment and their availability, the uptake has actually been slow in Africa. So only 26% of Afro countries and 56% of EMRO countries reported access to DAAs for first-line therapy. And for HBV, we are at 44% of Afro and 63% of EMRO countries. So there is still a lot of work to do to make sure that these treatments are accessed by the people who need them. So what are the drivers and the barriers to access to these medicines? So the first access barrier is affordability, and the first factor of affordability is usually linked to patents. So to summarize, when there is a patent, there is one supplier only, which means that there is no competition and that the prices are high. And when there is no patent, there is ability to have multiple producers and to have competition and to decrease prices and make the medicines affordable. So in terms of HBV and HCV, for HBV, there is no major patent barrier in Africa. So tenofovir and the treatments used have no patents any longer, as the patents have expired. And the cheapest price on the markets are very low, of $32 per patient per year in many countries. For HCV, when the first treatments came on the market, there were huge barriers linked to affordability and patents, with treatments who arrived at $48,000 $1,000 in the US, and which was completely unaffordable. And there was a huge fight led by civil society at the global level to ensure generic access to developing countries, and there were really drastic price reduction in a very short time. It's really an example of one disease where the prices have been able to decrease really fast due to advocacy and political will. So right now, the lowest prices are here in Egypt of $78 per cure, and in many developing countries, the price is situated around $150. There are, at the moment, very few patents. There are very few patents that were filed in the continent, and where they were filed, some of them were actually rejected, especially in Morocco and in Egypt. There is local production in several African countries, so in Egypt, in Morocco, in Tunisia, in Algeria. And all African countries, or roughly all African countries, were included in voluntary licenses, enabling them to procure medicines from Indian generics as well. So the generic barriers which were there at the beginning are no longer really an issue for the African continent. And there is theoretical access to generics, and this is a table of the lowest prices on the market and the target prices, so the estimated costs. And as you can see, the estimated cost and the prices we should go towards are really low, and affordability should not, in theory, be an issue in Africa. So there are other barriers which are not directly related to patents, but also affect price and availability. So they relate to transparency, to regulatory, and to procurement obstacles. So this is a map where you can see that roughly all African countries are included in sofosbuvir and daclatazivir licenses. However, when you look at the map and you see actual registration from originator companies, almost no countries have registration. And for some companies and for some countries, generic companies cannot enter the market when the originator company has not registered in the country. So this is an additional barrier which is not often considered. Another barrier relates to access to tenofovir. So as I said before, tenofovir is largely available in HIV programs, in HIV national programs. However, sometimes they are only available for HIV-infected people and not for HBV-infected people, or at different prices because the medicine has been registered only for HIV use, and the same medicine for HBV is going to be a lot more expensive. And in terms of HCV drugs, there is also huge variances in terms of prices, and there are prices that are very low, but also prices that remain high in comparison to other countries. So for instance, in Côte d'Ivoire, one bottle of sofosbuvir in 2015 costed $500 in comparison to the lowest prices which we have mentioned. And one issue is that there is lack of transparency and that countries don't necessarily know what their neighbors are paying and what the lowest prices they could access actually are. So they pay higher than they should. So in terms of challenges and opportunities for scale-up, the first important thing for countries is to have ambitious national strategic plans. And on the continent, it's quite unequal. And we still have only 52% of Afro countries which have national strategic plans, and 82% of EMRO countries, so EMRO is doing a bit better on that side. However, when you look at actual funding for these strategic plans, the number are much lower. So only 22% of the national plans in Afro region have funding, and 44% for the EMRO region. Another barrier is that you have lack of epidemiological data, as you know, so it's not always easy to know who to treat and where to treat them. Another barrier on the continent, and it's not only related to Africa, but contrary to HIV, where there's always been strong civil society voices for HIV, in HCV there is a lack on the continent of civil society organizations involved in hepatitis. And civil society plays a huge role in terms of advocacy and in terms of demand creation, so it's really important that these actors are supported, the actors that exist. And a study was conducted and showed that actually 84% of countries with a national elimination plan had involved civil society. So we can see here the real impact of civil society engagement in making things happen sometimes quicker. A huge barrier, of course, is the lack of funding at the global level. So it's not like HIV where we have the global fund. We have no global funding mechanism for HCV. So it's really important to be creative and to find new sources of funding and to reach our targets. So the needs are of $6 billion per year to reach the 2030 targets, and the current spending is only of 0.5 billion US dollars in 2016. So there's a huge gap to fill in terms of funding. So there is one success story, which is the case of Egypt, which you have heard about already, so I'm going to be quick. But among the reasons for this success is, of course, strong political will, ambitious planning and target setting, which enabled a strategic plan which was decentralized, which was ambitious, and enabled the screening of 20 million people and the treatment of 2 million people. There was resource mobilization, which was, as was shown in the previous session, very innovative and inventive, and which was multi-sectoral. So there was a national budget, there was fundraising through mobile technologies, involvement of the private sector and pharma companies. So all these elements enabled things to really move forward. It's also important to say that when Egypt started putting people on treatment, prices were much higher even in Egypt. And there were of $900 US prices proposed by Gilead, and that didn't stop Egypt from starting. And at the same time, there were these price negotiation strategies that were put in place to make sure that the treatment was going to be more affordable. So there were negotiations with pharma companies. There was a public health approach to patent examination, and the main patents were actually rejected, also following a public health rationale. And local production of medicines, of course, started, which had a huge impact. And last thing is that there was a really multi-sectoral involvement, so civil society, community-based organization, the media were all involved to make sure that the campaigns and the plan would reach the largest number possible. So for conclusive remarks and summary, we have met ambitious targets globally in terms of improving access to HBV and HCV. However, Africa is still lagging behind in comparison to other regions. There is a limited portfolio of medicines which we actually need and which exists. So with these medicines which are on the market, we can achieve huge progress. And generic versions are available, and lowest prices on the market are low. So in theory, price and affordability should not be an issue. However, there's a number of other issues which we mentioned, including registration, procurement, etc. There is a high potential for local manufacturing, so of course Egypt is leading the way. We also have local manufacturing in other Northern African countries, and it's really important that we go further in that area and that we go further towards more independence from procuring from foreign companies and Indian companies and originator companies. We need strong leadership and political will in the continent. It's really important also, as I said, to underline the role of civil society in terms of advocacy and demand creation, and to really support civil society to really work together. And finally, the funding gap really needs to be addressed, and it's important to think of innovative funding, as was done for HIV, with all the panel of funding solutions which were thought throughout the years, and to involve a number of different actors, including the private sector, etc. And I'm going to finish here. Thank you for your attention.